Assalamu alaikum, everybody. Good evening. I'm delighted to be here again in the DAR conference of 2023. I'd like to thank the organizers for the successful conference so far, and I'd like to thank the Merck for inviting me to be part of their symposium. And I'm also extending the thanks to you guys, dear colleagues and friends, for sparing your time being here during your leisure time for mutual exchange of clinical knowledge and experience. My talk is pretty short, and I'll just try to go beyond the efficacy of metformin in around 15 minutes or less. And because of the time constraints, I'll go directly to the objectives that during the coming 15 minutes, I'll be going through the efficacy of metformin at various glycemic backgrounds and metformin at different strength and formulations. And we'll conclude by going through the metformin in clinical practice. We probably know that we have nearly above 40 different types of glucose lowering agents, but the more popular formulations of hypoglycemic agents include metformin, sulfonylurea, TZDs, GLPs, 1 receptor agonists, SGLT2 inhibitors, and DPP4 inhibitors. And amongst those, the metformin and the sulfonylureas are considered one of the strongest glucose lowering agents, since they are able to grab the HbA1c down by 1.5 to 2%, especially when they are initiated at early stage. So this is followed by the thiazolidinediones, and currently we have only the pioglitazone, then followed by the GLP-1 receptor agonists and other classes of glucose lowering agents. So monotherapy of metformin or sulfonylurea may grab the HbA1c down to 2% from the baseline at initiation time. And the metformin works at different pathophysiologies of hyperglycemia and insulin resistance. So the metformin monotherapy may reduce the fasting blood glucose by an average of 23% from baseline until just 6 to 12 weeks after the initiation time. It's able to grab the HbA1c, as we've just mentioned, to 2 to 2.2% from baseline to 3 months down the line. And it has also a remarkable effect on hyperinsulinemia, which is a major contributory factor to pathology of hyperglycemia and diabetes. So it has multiple facets in treating hyperglycemia and insulin resistance. It's not only the role of metformin in hyperglycemia and type 2 diabetes, established diabetes. Metformin has also a remarkable role in preventing diabetes from happening, and therefore it's been used widely at the state of pre-diabetes. And this is the Diabetes Prevention Program of the United States, where they included over 3,000 patients, and they randomized them into placebo, metformin arm, and intensive lifestyle intervention arm. And metformin managed to prevent 30% of the randomized group into metformin from having type 2 diabetes. So every year, 30% of the patients who are on metformin and they have pre-diabetes, they are protected if you can mention it like this way, they are protected from having type 2 diabetes, and 30% every year if they carried on to continue taking the metformin as the time goes. Intensive lifestyle modification managed to grab the risk of developing type 2 diabetes even more, but the sustainability of having just intensive lifestyle intervention is not easy, as we all know. So does the dose of metformin matters? The answer is yes. So we've always heard that the minimum effective dose of metformin is this much. So this is the pharmacodynamic study that showed the higher the dose of metformin, the more efficacious the molecule is. So with 500 milligrams, just around 20% efficacy, and it goes more in the reduction in fasting blood glucose. As the dose of metformin goes larger, the effect on fasting blood glucose is higher, and this is definitely represented in the HbA1c that leaves us with the minimum, or the minimum effective dose of metformin, or the desired dose, we can say, is 2 grams in people with type 2 diabetes. The different studies have shown the minimum effective dose is around 1.5 grams. So what we can say is, to attain the maximum benefit from metformin in people with diabetes, we need at least 1.5 to 2 grams of metformin. And this is another meta-analysis that concord what we've mentioned a while ago, that the higher the dose of metformin, the 2 grams here, outweighs the benefit from having the metformin at 1,000 milligrams or 1,255 in other studies. So almost all the studies were in favor of having the metformin at a dose of 2 grams per day. So does the formulation of metformin matters? And again, the answer is yes, especially in terms of the side effects. This is a pooled data from clinical trials that have shown the side effects of immediate release metformin has been blunted or reduced by 50% when the people has shifted to or were taking the metformin, the extended release formulation, especially the diarrhea and the nausea and or vomiting. And we all know that the GI upset or GI side effects of metformin are usually reversible side effects, and usually takes a couple of weeks until it settles down, except only few people who continue to have remarkable GI upset. Another study have reviewed over 470 patients. 2/3 of them were on metformin extended release, and 1/3 on immediate release metformin. And the difference in all GI adverse events was almost halved when the people used to take metformin XR. 11% in metformin XR extended release compared to 26% in immediate release metformin. More than half of or more than 50% reduction in GI upset side effects or side effects. So that takes us to the role of metformin, or the place of metformin in the clinical guidelines. I'll just quote one guideline, the American Diabetes Association and the European Association of Study of Diabetes guidelines, where they highlighted the importance of metformin, and they elaborated that the metformin is an efficacious drug, carries a very low risk of hypoglycemia, and here they mentioned that there is no risk of hypoglycemia, potential cardiovascular protection, and they recommended that the metformin should not be used if the GFR is less than 30%, and this is the FDA approval so far. And they memorized us that the cost of metformin is extremely low. And they summarized the recommendation as follows: that metformin is traditionally been recommended as first-line glucose lowering therapy for management of type 2 diabetes. However, there is ongoing concept or acceptance that the other approach may be appropriate, and they are highlighting here the cardiorenal protection. So whenever the initiation is of glucose lowering agent is needed, and the HbA1c is less than 1.5% from the target, metformin would be a reasonable first-line therapy, unless the patient is having other comorbidities, and that's different context. So whenever the HbA1c is between the target and 1.5% away from target, the metformin would be the first-line therapy. We are in DAR conference, so we cannot pass without visiting the diabetes guidelines during the month of Ramadan, and they quote the International Diabetes Federation and their guidelines of 2021 on metformin. And this is, I just quote the recommendation as it is, that the severe hypoglycemia in non-fasting individuals receiving metformin is rare. And while there are no randomized controlled trials on the use of metformin in people with type 2 diabetes that's fast during Ramadan, it's considered safe for individuals on metformin monotherapy to fast. And they elaborated the recommendation, what I call not a dose adjustment, it's actually timing adjustment or timing modification during Ramadan, because the dose of metformin remains the same, whether it's in immediate release formulation or the extended release formulation. So if the patient is on once daily, there is no dose modification is required. Take it as if at iftar. If the patient is having twice daily for dosing, there is no modification of the dose. Take one at iftar and the other one at suhoor. If the patient is having three times formulation, and this is most likely the immediate release metformin, then to take 2 tablets at iftar and 1 tablet at suhoor. And if the patient is, and now most of the patients are on the extended release or the prolonged release metformin, there is no dose adjustment is required again, and take the tablets at iftar time. So with that, Mr. Chairman, dear colleagues and friends, please allow me to summarize that metformin is a potent glucose-lowering agent with a large safety and tolerability profile. Metformin plays a role from the pre-diabetes status until advanced diabetes, and we can continue until the moderate CKD, sorry for the typos, CKD, not CHD. Metformin extended release is more tolerable and preferred by people with diabetes as well. Minimum diabetes effective dose would be 1.5 to 2 grams per day, and metformin is a safe drug during Ramadan. Consider timing modification, and that's it. With that, I'd like to thank you very much for your attention, and I'm happy to take any questions, if any.